People are still trickling in. Okay, so the recording's going. Okay, great. So, hi everyone. Welcome to the technical advisory group for the cost growth target for June. Um, Go to the next slide. So, just to review what we're going to talk about today, we're going to go over the agenda as we're doing right now. We will then have a couple of program updates, and then look at some of the outputs for the cost growth target report that was released earlier this month with the CGT1 data for 2022 to 2023. After that, we'll go over some data, some expectations for the data submission for this coming September for both CGT1, the cost growth data, and CGT4 workforce data from the provider organizations. And then we'll have some time for folks to ask any questions they have about those data submissions happening in September, and then we'll close out. Any initial questions? I'm going to say no. Okay, program updates. Um, so, I think we've touched on this in previous TAG meetings. As many of you may recall, the Oregon Health Policy Board is starting up a new advisory committee on affordability. And we've been recruiting for that committee. So there's the affordability committee itself, which is primarily sort of consumer reps and folks who are healthcare users. And then there's an industry advisory committee, which is kind of what it sounds like, folks from the industry, payers, providers, et cetera, who have formed another committee to provide technical advice and feedback to the affordability committee. We finished recruitment for both of those committees recently, and the rosters are now live online. There's a couple of links in the slides here. We I posted the slides the last few this morning rather. So if you want to go look at the rosters, you can look up the links on the TAG website and then find the rosters online. In terms of next steps for these committees, there is going to be a period of member orientation, and then we'll start scheduling meetings. So it's kind of in process at the moment. Okay. Yeah, in process at the moment. And we will keep you updated as their activities unfold. Okay. Our public hearing happened earlier this month, the 2025 cost growth target public hearing that was looking at data that you all submitted for 2022 to 2023 healthcare cost growth. That was held on June 10th, not long after the annual report was released the week earlier. The slides and recording of that are now online. We focused in this year's report mostly on statewide growth and payer growth. We are still working on finalizing provider data for the period. So weren't able to publish that yet, but that'll be published later. The recording, just in case you look it up, is actually the Oregon Health Policy Board meeting. So the healthcare cost growth target program annual hearing doesn't start until midway into that meeting, so you'd have to go to about 2 hours in. And related to that, we had two reports released this month. The 2025 healthcare cost growth trends in Oregon for 22 to 23, as I just mentioned. No provider data for the moment. We'll release that separately. And then also the impact of healthcare costs on people in Oregon 2024. So that's kind of a broader document looking at data from a number of different sources that's updated on a periodic basis, looking at affordability metrics, things like increases in premiums and deductibles, and folks who are struggling with medical debt in Oregon. 2024 data validation and reasonableness updates. So we are still working through some follow-up on the data that was submitted last fall. We published the report, obviously, recently, but as I mentioned, on the provider organization side, had not finished that validation process, so weren't able to include provider organization data in that report. On the payer side, though, at this point, we have completed validation with all payers. We're still working through a couple of outstanding questions about attribution. This was a particularly challenging validation period this year, I believe. And as a result, we had a couple of outliers with many resubmissions, and one pay to issue civil penalties based on data errors in their submission. So yeah, we are hoping to improve upon that next year and receive more quality data, and have less issues and be able to issue our report on time with everyone's data included. On the payer side, the determining reasonableness process has been in progress for a few months. We've met with most of the payers at this point to discuss the cost growth. But yeah, still reviewing some follow-up documentation that was sent to us, and we still have a couple of payers who we haven't met with. So we'll be meeting with them over the coming weeks. On the provider organization side, as of this June, we had met with 36 provider organizations to review their 2022 to 2023 data. And we're currently kind of wrapping up that process with some follow-up from those meetings. We are going to be reissuing probably most providers' data relative to what was sent to you in January. That's because we had a number of issues related to validation that were surfaced over the spring months. Mostly things like attribution issues and some issues with non-claims spending and payer data submissions. So look out for that in the next couple of weeks. We will send that to you along with any follow-up on outstanding questions that we might have had for your organization specifically. And then also for those of you whose data is finalized, which should be most of you at this point, we'll be sharing with you whether or not we are requesting a reasonableness determination meeting and starting that process at the provider level. So that's most of the updates that I have. For program updates, does anyone have questions on any of that? Oops. Struggling a little bit to share my screen at the same time as look at whether there's anything in the chat. I'm not seeing anything pop up. Okay. Since there are no questions at this time, I think we can move on to reviewing some of the data. So this is going to be a little repetitive if you were managing to attend the public hearing earlier this month. Basically, these are our slides on the outputs from the report from the public hearing. But we wanted to make sure we share it with y'all because we appreciate the work that you put into putting the data submissions together for CGT1, and I hope that you think it's interesting to sort of see the output from your labor. So Looking at cost growth at the statewide level, we had healthcare cost spending in Oregon in 2023, totaling around $39 billion. Total healthcare expenditures per person per year were $10,302 per person in 2023, and that was a 5.2% increase over 2022, including all of the data submitted this year and tracked for healthcare costs in Oregon. So as you can see, that's kind of ticked up a little bit from the year prior. 21 to 22 cost growth was 4.8%, up from 3.5% in 21, and then negative in 2020 due to the pandemic, but coming down from 3.6%. So excluding the period of the pandemic when there was that decrease in utilization, healthcare cost growth has been above the target in every period that we've been tracking it over the past five measurement periods. Any questions? Okay. So kind of looking at the breakout of that $39 billion figure, on the left is a pie chart that kind of shows where that spending is going. Medicare accounted for the largest share of the healthcare spending in Oregon in 23. We had around 35.2% of total healthcare expenditures going to Medicare costs, and that's both Medicare, traditional Medicare fee-for-service, and Medicare Advantage. That was followed by commercial at 25.7% and Medicaid at 24.9%. So each of those had about a quarter of the spending on healthcare in the state. And CPHI, which is the difference between premiums collected and healthcare spending, was about 6.7%. So that goes to admin costs and profit advertising for insurers. And then the other bucket, which includes a number of different things, for example, spending by the VA and other state spending on behavioral health programs, that comprise another 7.5%. And then on the right, there's some bar charts for 22 and 23, just showing in billions how much spending there was in each of those categories. This slide is looking at trends in healthcare, total healthcare expenditures and Medicaid, Medicare, commercial, and NCPHI over the total period that we have collected for cost growth target data. So 2018 to 2023, on the lower axis, if it's 2019, that's for the 2018 to 2019 period, growth period, and kind of similar up to 2023. So in the most current period, looking at state total healthcare spending per person per year at the statewide level, we had a 9.0% increase in Medicaid spending. And so for Medicaid, that includes CCOs, open card, and then other spending, which is things like health-related services going to CCOs. Medicare was 7.8%, and that includes both Medicare fee-for-service and Medicare Advantage. Commercial, 6.3%, which includes both full and partial claims. And then NCPHI, which is only applicable to CCOs, Medicare Advantage, and then commercial, decreased in this period 12.7%. Which might be expected with the increasing healthcare costs. A larger portion of the premium dollars collected in 23 was going to healthcare as opposed to to NCPHI. Any questions on the last two slides? Oh, I got a couple chats. Is there data showing cost growth percent broken down by Medicaid, Medicare, and commercial? Yes, I think that might have been asked before I got to this slide. Okay. Next slide. So this is looking at those service categories that we collect from the Costco Target program. So at both the statewide level, so that's basically everything together. This is total medical expenses, I should mention, which doesn't include NCPHI. It's really just only spending on healthcare claims that were processed and non-claims payments made to providers altogether. So for TME, at the statewide level, the largest increase, the service category with the largest percent increase on a person per year basis, was actually medical pharmacy, which is a new category this year, that we didn't have in previous years. This year we have it thanks to some changes we made in the data submission. So we appreciate the work that you did to integrate that. Yeah, so medical pharmacy statewide, and that's only including commercial, Med Advantage, and Medicaid, grew 12.6%. And you can see some variation. The growth rate was higher for Medicare Advantage, at 18%. We don't have that breakout in this graphic for traditional Medicare because the data that we receive from CMS doesn't break things out at that level. However, we did do some supplemental analysis in APAC with the CMS claims data that we have there, and the cost growth for fee-for-service Medicare and medical pharmacy was fairly similar to what you're seeing in Medicare Advantage. So not a huge difference. Yeah, and then commercial and Medicaid was around 10 to 11% increase. After medical pharmacy, there was a large increase in non-claims payments. You can see that that was concentrated really in Medicare Advantage. Medicaid kind of held steady in terms of its non-claims cost growth. While commercial, where that spending is like fairly low to begin with, actually decreased by 22.5%. And then I think one last area that's worth highlighting is the professional behavioral health. You can see for Medicaid, there was a 23.4% increase in behavioral health spending. And a lot of that is related to state policies that put more money into behavioral health during this period, those directed payments, behavioral health directed payments, increasing that. And then commercial, based on our understanding from talking to a couple of payers, it sounds like the commercial market insurers were just investing more in behavioral health to potentially increase their networks and have more providers offering services. Any questions on this slide? Oh, got one question in the chat. Looks like interesting, significant increases with non-claims for commercial. Yeah, yeah. Medicare Advantage, there was a large shift. Some of that was, there was one payer that was shifting a lot of their costs from claims categories to non-claims. So that was highly influenced by one particular payer. And then at the commercial level, as I mentioned, there's like that spending is so low to begin with that even tiny changes on an absolute level look like giant percent increase changes. So we have another graphic in the report that looks at absolute change. And if you look at the commercial one for that, you see that it's like a very small absolute dollar change for commercial spending. statewide changes are 0 for professional primary. I should explain the reason that at the statewide level, we only are tracking the professional category writ large because the data that we get from CMS isn't broken down by the same subcategories that we have for the CGT data submissions. So we could calculate something at the statewide level for those subcategories, but it would only include like half of Medicare, Medicare Advantage, basically. CMS traditional Medicare would be left out, so it wouldn't be like a full representation. But yeah. So the 7.6%, yeah, so that's maybe we should like highlight that category or something. But yeah, that's the overall across all of those professional subcategories. And as you can see, that was a significant increase as well. And that's where a lot of the spending is. So in terms of what had the influence on the cost growth, I think professional spending is definitely up there. Yeah. Cool. Okay. Yeah, and then so for this year, we also did some supplemental analysis in APAC to go along with report on price versus utilization growth to kind of get a little bit more information about what was driving growth in these different categories. So I'm going to hand it over to Yishan to go over a couple of slides looking at the APAC analysis. And there we go.
Thanks, Margaret.
Oh, sorry. One more question. Does Medicaid category include the state's costs for open card members? Yes, it does. So now going to Yishan.
All right, thank you, Margaret. Can everyone hear my voice okay?
I can hear you.
Okay, good. All right. Good morning. I'm Yishan Song, she, her. I am a data analyst with Cost Growth Target Program. And so this year, in our annual report, we included the price versus utilization analysis from Oregon All Payers All Claims database to supplement the cost data we collected from CGT. It is to help to identify whether the spending increases are driven by price or by number of services being provided. So you see this bar chart show the statewide data from 2022 to 23 in Oregon's claims database. The checker pattern is the cost per person growth, and the dark blue bars are the price growth. The light blue bars are the utilization growth per 1,000 people. For utilization, we use the 1,000 people in the denominator to control the population changes over the years. So in this chart, we can see the primary drivers of the cost growth for the statewide was price, which increased by 7.9% in professional services and 7.1 in outpatient services. The utilization also contributes some of the cost growth, like 4.2% increase in professional services, but the number was lower than the price increase, which is 7.9%. And for the retail pharmacy, the cost growth was driven by both the price and the utilization, as you can see from the chart. This is the statewide data. In our annual report, we have the numbers by market, so maybe we can put the link for annual report later in the chat, and feel free to check that out if you haven't gone through that yet. And next slide, please. So we also include our price versus utilization data in the report back to 2018. These line charts show price has been the primary cost driver over the years. As you can see, the dark blue lines keep increasing over the years. The utilization is more fluctuated across years. For inpatient and professional services, the utilization was actually decreased. So the price definitely the contributor for the cost growth in these two categories. And for outpatient and retail pharmacy and other services, we can see the increase in the utilization, but the price still the main cost driver over the years. So that's the trend from the APAC data. And I'm pass it back to the Margaret for the other slides. Thank you.
Thanks, Dishan. Does anyone have any questions? Looks like we got one in the chat. Does Medicaid, let's see what to do. Tiffany's been posting the reports. Thanks, Tiffany. Great. So I'll move on to, let me see, there might be one more comment. I noticed services being performed by certain types of nursing professionals seem to have a higher rate of growth than other professions. Is that something you look at? I don't, yeah, that's not something that we looked at specifically in this report, but that's a good observation. Interesting. Yeah, we do have also, so we did collect the CGT4 data, which is the workforce data, frontline workforce reporting data that was a new data submission this year from the provider organizations. That data for 22 to 23 has been, we have it finalized. We just haven't had time to do a full analysis yet. But we're hoping to do that sort of the next month or two and release a short report on healthcare workforce costs. So that won't specifically get to the nursing professionals question, but it would kind of provide some comparable workforce data overall that you guys will be able to look at. But so watch out for that in the next maybe 2 months or something like that. Okay. So now we just have a couple of slides looking at TME, total medical expenses. So TME again is the claims plus non-claims spending on medical care. So we have that by market. The report is organized a little bit differently this year. In the past, we had one chapter in statewide growth, a chapter in service category growth, and then one chapter each for payers and provider organization cost growth. This year, we reorganized it a little bit. So we are looking at cost growth by market. So there's a statewide chapter and then one chapter for each of the markets that we track for CGT. So yeah, we can kind of organize the slides in a similar manner here. So this is looking at TME growth in the commercial market from 2018 to 2023. And I believe this includes both full and partial claims in this graph. You can kind of see a lot of fluctuation over recent years due to the pandemic, that decrease in 2020, and then a giant bounce back in 21. And that kind of decreased again and increased in 23. But overall, the average cost growth across this period, so this is all years of cost growth target data, was 4.6% average year over year. And this year it was 6.3%. So definitely higher than the target overall. There were a number of drivers at the service category level of that, as if you might recall from the statewide service category growth slide a couple of slides ago. There was a lot of growth in professional behavioral health and professional services in general, but hospital outpatient price increases were also a major contributor to cost growth, a lot of that on the facility spending side. No payers in the commercial market this year met the cost growth target. There were a few who were indeterminate, so their confidence intervals, the lower bound of their 95% confidence interval did not exceed the target, but no one met the target, which would have meant that the upper bound of their confidence interval was below the 3.4%. I think I saw another comment, more web pages from Tiffany. Yeah, so this was more or less what was happening in the commercial market, high cost growth, and elevated over the entire cost growth period. Um, so for Medicare, we have this graph, which is broken out by Medicare Advantage versus traditional Medicare. They're fairly two different ways of managing costs, and two different kind of data sources. So we look at this with the two of them broken out. Also, at the payer level, we're only measuring cost growth for Medicare Advantage, so it's kind of interesting to have a reference point for those Medicare Advantage payers. But looking at this graph, you can see sort of similar fluctuations due to the pandemic, and somewhat higher growth for Med Advantage, or actually the same growth for Med Advantage this year, when compared to commercial at 6.3%. Traditional Medicare was a little bit higher at 7.3%. And in terms of the service category drivers, professional services grew a lot. Retail pharmacy and medical pharmacy together also accounted for a very large proportion of the growth in both CMS and Med Advantage growth. As we mentioned and saw earlier, non-claim spending also increased a lot for Medicare Advantage, largely related to one payers sort of shifting from claims to non-claims. And we had one payer who met the target this year for Medicare Advantage payers, data submitters. Everyone else was either indeterminate or over the cost growth target, which is potentially not surprising given the high growth on average overall in the market. Any questions on Medicare? Okay. So finally, Medicaid. So you can see in this graph, the cost growth in Medicaid has been very low overall, the last three periods prior to this one. That was related to a number of things. There was the drop in utilization in the pandemic, and then we also had kind of a surge in enrollment because of pandemic era policies and sort of pausing of redeterminations. So the last couple of cost growth periods, the cost growth in Medicaid has been kind of muted because they had a lot more sort of lower cost, low utilizers who were joining the rolls of Medicaid and bringing that PMPM or per person per year spending down. Yeah, and then this graph is looking at both CCOs and open card together. Looks like we have a question in the chat. Do we have preliminary 2024 data as well? The 2024 data is going to be collected in September, so that's not going to be released until next year, because we have a claims run out period that we give for the data. It's actually only coming out at the end of this June, will be the end of the claims run out period for 2024, and then payers can start pulling the data at that point, and sending us the 2024 data for 23 to 24 cost growth this September. With our Medicaid population, we've seen a massive increase in claims coming from peer support specialists. That wasn't something that we looked at specifically, but I wouldn't be surprised if we did some digging in APAC if we would find evidence of that in the claims. I think we're to the point with the program and our data analysis currently where we're only starting to try to integrate some more analysis from APAC into these reports. But I could definitely see in future years trying to do a little bit more of a spotlight on topics like specific types of practitioners whose claims are increasing over the period. So yeah, kind of in answer to your question, we haven't looked into that specifically. I will say that basically the biggest drivers in Medicaid during this period were state mandated benefits. So basically, the behavioral health directed payments. We saw an increase in both price because the state increased the prices paid. But then also in utilization, there was kind of a knock-on effect, which I think was the intention, where those increased prices increased the capacity and the number of people who were getting served, accessing those behavioral health services. There's some supplemental analysis in our report looking at costs versus utilization or price versus utilization specifically in behavioral health. So you can see that it was both utilization and price driving that, and that was one of the really the top drivers of cost growth in Medicaid in this period. There was also increases in hospital outpatient and hospital inpatient prices in Medicaid that were also due to state policies increasing DRG payments and payments to DRG hospitals, so both inpatient and outpatient. Um, so yeah, so there was pretty high growth across Medicaid this year, mostly due to behavioral health and hospital costs, and that was related to state policies. But also some other periods or other categories, depending on the specific payer or specific region where the cost growth was happening. We did have 4 CCOs that met the target, but the vast majority surpassed the target this year, largely because of the behavioral health and hospital increases. Okay, so that's Medicaid. We're getting towards the end of these slides. So this is looking at just uh, payer cost growth overall in relation to the target. As you can see, the vast majority of payers exceeded the target, mostly with statistical confidence this period. There were a few in commercial, as I mentioned earlier, and Medicare Advantage that were indeterminate. And then we've got those five payers who met the target this year, off on the right side. And just to review, the green is Medicaid, red is Medicare Advantage, and the orange is commercial. Looks like there's a question in the chat. And these slides, the 5-year averages look like, yeah, that sounds likely. Yeah, I think highest cost growth just historically has been in the commercial market. It's just like the last couple of years, it's been such a strange period to start tracking things for the cost growth target program with all the fluctuation due to the pandemic. Thanks for that, Travis. Okay. Yeah, so I think I've already kind of gone over some of this a little bit, but yeah, we haven't finalized or published provider organization data yet for the measurement period. We're working on that the next few months, and hope to be on kind of a better track for next year's data submission, to be a bit more timely in releasing the data. We also haven't published any reasonableness determinations for payers or provider organizations. We're a little bit farther along with the payer determinations process. Kind of depending on how things shake out, we might release the payer determinations before the provider determinations. I think it's sort of to be decided. New message. Okay. Great. Okay, so I'm going to move on to my next section. Any last questions, I guess, about the CGT data? Okay. questions, discussions? I think I already covered that. Okay, so moving on to 2025 data submission expectations, and then we'll have a little bit of time for anyone who has questions about the upcoming data submissions. And this is for 22 to 23 or 23 to 24. I'm used to saying 22 to 23, 23 to 24 cost growth data. 2025 data submission covers calendar years 23 to 24. Reporter notification. I think we covered this in previous tags a bit as well. We sent all of those notifications out in April. Most for CGT1, the cost growth data, and for CGT4, frontline workforce compensation data. Payers and provider organizations that are mandatory data submitters received that notification mid-April. And then around April 29th, we sent messages to voluntary data submitters for both CGT1 and CGT4, including information about that submission if they choose to submit. Okay, I had one question that I missed earlier. Given the substantial cost increases, are there suggestions that the team is making to help drive down trend? Yeah, so at this point, I think we'll see how things go with the PIP process. If we have a following reasonableness determination processes this year, we might have a payer or provider organization put on a performance improvement plan. And in that case, we would be working closely with that entity to look at ways that they, at their level, could work on getting their cost growth down. At the state level, we also have the affordability committee that will be working in tandem with as they come up with policy recommendations for addressing cost growth. Thanks for putting those committee pages in the chat, Tiffany. Great. 2025 data submission for both CGT1 and CGT4 is due Friday, September 5th. This is a little bit different for CGT4. Last year when that data was submitted, the due date was in December. That was just because rulemaking kind of ran through the summer, and so we didn't have the data submission template finalized until like right close up to the time. But this year we had the able to give all the provider organizations notice all the way back in April about submitting their workforce data. So going forward, those two. Okay. So yeah, I mean, basically we just wanted to have take a little bit of space to kind of discuss how things went with the data submission this last year, which was a bit rough, and set a few expectations going forward. First off, just talking about data submission extensions. We have a little data up here showing for CGT1 how many extensions have been granted in all of the 4 data submission cycles that we've gone through so far. The most extensions were granted in 2022, it looks like, but then this year we had an elevated number. We had 6 out of 19 payer data submitters requesting and receiving extensions of the initial September reporting deadline. And a lot of that was related to the fact that we had some new data reporting requirements this year. We had the medical pharmacy, and then there was also a sort of an addition of a CCOF reporting requirement in August, not long before the initial submissions were due. So we had a number of extensions granted for those reasons. This year for CGT1, there's kind of only minor changes to the template and to the data submission process. So we're really hoping to not have the same number of extensions because that just kind of pushes everything back from the start and holds up the process. We also had 6 out of 25 provider organizations that had a CGT4 submission last year receiving extensions or submitting the file late. So all of this is just to say that we are anticipating granting minimal extensions this year. So hoping everyone can organize themselves with any competing deadlines to get everything into us on time. And then, as I mentioned, and as is potentially apparent in this graph, we had sort of a rough data submission cycle this year. Only 8 of the 38 files that we received across all of the payers for CGT1 didn't have a resubmission. A lot of the resubmissions this year were due to the medical pharmacy requirement that was added in, and folks having to adjust their data submissions due to errors in the medical pharmacy side. But then, as you can see, there were a number of outliers with a very high number of resubmissions as well. So we're really hoping to move this distribution back towards more people just having 0 resubmissions. This year, the number of resubmissions that we had was really made the whole annual cycle, I think, push back in terms of reasonableness and reporting for the annual report. And as mentioned, resulted in not having provider data ready for the report this year. We may be potentially moving a little more quickly this time around to issuing notices of noncompliance. Although, we do recognize everyone is for the most part doing their best to get us good data and with minimal errors. But we do have that tool to sort of move things along. So we might be utilizing it a little bit more this year, potentially. Hopefully not. FQHCs are still exempt, Blaine. Yes, so you don't have to submit CGT4 if you're an FQHC. So yeah, you might have received a voluntary reporter notification, but unless you got the message, and there's also the list of mandatory data submitters is up on the provider organization webpage. Kind of in the same vein, and maybe a little repetitive, but looking at CGT1, just tips in terms of how to avoid having resubmissions, and sort of what is OHA doing on our side to help try to reduce the resubmissions. We integrated new validation checks for medical pharmacy. So a lot of the checks that we were requesting resubmissions after that we had developed on our own are now in the data template for you to use yourself. Essentially, the main issue with medical pharmacy data submissions was that at various levels, the medical pharmacy costs were not a subset of the overall costs in the claims categories. There's now a couple of checks in the data template that should allow you to look at whether that's an issue yourselves before you submit it to us. So we really encourage you to look at the contents of those validation tabs before submitting. Just a reminder as well that there's a section in the data manual that has some recommended validation checks before file submission. And that's just sort of the basic do things add up checks that you can do before submitting to us and hopefully catch some of those things ahead of time. We're also going to be trying to take a closer look at attribution to accountable provider organizations during the payer validation period because, we are able to track changes in attribution, and sometimes that's indicative of there being a data issue if the provider attribution is changing a lot from year to year. We had some checks that we were doing last year, but I don't think that they could be improved upon. So hoping to tackle some of those attribution issues a little bit more upfront instead of during provider validation. On the CGT4 side, the data submission was it's a lot simpler for the most part. And even though it was a new process this year, I feel like the validation process was fairly easy. We did have some payers who didn't completely, or payers, provider organizations who didn't completely follow the specifications in the template, submitted the wrong years of data, et cetera, or had some basic issues with total operating expenses, not including total compensation, et cetera. So to help you before your submission, we added a data validation tab to that this year. We also added a little bit more guidance in the template itself with some comments on the different data fields about what goes in them and a few more answers in the FAQ at the end. And I'd say with all of this, if you're in doubt either at the payer or provider level side and what to put in your data submission, just write to us at the Healthcare Cost Target inbox, and we'll get back to you with our response to any questions you have about the data submission. Okay. And then finally, just one last plea. We had over the last two periods, which were the first two periods that we had both the data validation process and the reasonableness determination process, we had several payers who didn't identify errors in their submission until they met with us for reasonableness, at which point they made us aware of issues that they had to correct, and that brought their cost growth down. That is not the ideal process to have happen. We would really like the validation to have been complete before the reasonableness process. So anything you can do to send us data that doesn't need to be updated during the reasonableness process, and as soon as you see an error, just let us know. That would be highly appreciated to get the whole process a little bit more on track. Does anyone have any questions about any of this? Seeing no, and the next section is actually basically just office hours for data submission questions. So I think we can just move on, and I'll give it, I don't know, 10 minutes or something to begin with and see if folks have questions that they had for the upcoming data submissions. I've got, yes, thanks for putting the inbox in the chat, Tiffany. Okay. Yeah, fine to hop off if you don't have any at this point, if you don't think you have questions for the data submission office hours. But feel free to stick around if you do have a question or want to see if anyone else has a question. Have a good day, anyone who's hopping off. And as a reminder, we did post the updated manual and CGT1 data submission template a week or two ago. Tyler, for Medicaid payers, we noticed there's no instructions specifically how to handle when commercial is the primary payer on the claim. Oh, that's interesting. Yeah, I mean, I assume that does exist as a situation,
Yeah,
but
and
it's not.
I can
Yeah.
speak to that more. Sorry, I was like trying to quickly type it in the chat.
Yeah.
Yeah, I mean there are instructions for coordination of benefit claims where
Rules.
Medicare, yeah,
Yeah.
but especially since at least we're seeing dual eligibility in the sense of commercial is primary and Medicaid is secondary. We're seeing more growth in members with that kind of coverage.
Mhm.
Um, so just curious, you know, maybe in prior years it didn't, you know, swing results too much, but now just curious if there's specific guidance from OHA.
Yeah, offhand, not having consulted my colleagues, which maybe let's see, unfortunately, I'm sharing my screen, so I can't see if they have any comments. But uh, offhand, I think that the way that the data submission is currently set up, any of those costs would be broken out or would be like living in the commercial line of business because we're asking everyone to, in the commercial line of business, to report on total allowed amount. So it's both payer paid and patient paid. So I assume that if Medicaid is a secondary payer, it's usually you're going to be covering like copays or whatever's left over. Um, so I kind of, at the moment, offhand, not having consulted anyone, I feel like you can probably leave those costs out for the moment. And we split it out separately for Medicare and Medicaid because we wanted to have those duals costs kind of broken out. But I'm kind of assuming that any commercial payer costs are going to be like living in the commercial data submission at this point. And so you wouldn't need to submit that to us, but I'll consult internally and get you send a follow-up with like more explicit um, guidance if that sounds good.
Okay, yeah, I appreciate that. And that aligns with our like reasoning as well. Just wanted to double check.
Okay,
Okay, thank you.
sure. I'm just gonna take my sorry, I took the PowerPoint down because it was making it too hard to see what's going on my screen. Um, but yeah, that's a good question. I'm going to say probably don't worry about it, but we will get back to you for sure. Any other questions? We'll give it another couple of minutes. At some point, I'm going to assume that no one is messaging because they don't have any questions, and then we can all just sign off. And we're going to have another data submission office hours as well in a month from now during the July tag. We don't currently have much of an agenda for the July tag aside from office hours. So there'll be another opportunity to ask questions if you don't think of anything today. Well, I think I'm just going to call it. It doesn't seem like anyone else has questions and folks are kind of trickling off. So the next meeting will be July 25th, I believe. No, July 23rd. And we'll have another chance to ask any questions you have about the data submission at that point. So have a great day and thanks for joining us.